Probably the most important session of this meeting. The reason I say so is 50 to 60% of our specialty of pediatric surgery is urology, and the foundation of pediatric urology is urodynamic, and a deep understanding of this physiological subspecialty of pediatric urology is most important before you do any surgical reconstruction. So we have three experts here who are very experienced. Dr. Pati, my colleague will introduce the problem and the background and introduce the field of urodynamics to you, followed by our honored past president, Professor Ramesh Babu. And after he has given an introduction to the physiology and the false positives and the false negatives and the practical utility of the specialty, Subhashish Saha, an recognized expert in this field and very interested in this area, will enlighten us with some examples, problem oriented discussion, and then before we close, we would expect an active interactive session. I can only assure you that every day is a new day. We are all learning, so nobody is an expert. Feel free to ask anything. Thank you very much for your attention. Dr. Pati, are we going to start with you?
Thank you, sir, for that kind introduction. We have two experts with us, the stalwarts of urodynamics from our country. Uh, Dr. Ramesh Babu, I'll know about him. I need not introduce him. He is the past president. And Dr. Subhasis Saha, the दूसरा presentation कहाँ है? Okay. Dr. Subhasis Saha from Calcutta. He is also into the Pediatric Urology Society. He was the chairman as well as the secretary. And he is also now working with Manipal House Group of Hospitals at Calcutta. So let's start with a small poll. All of you are in the WhatsApp group. We have created the WhatsApp group. We will start with a small poll for the pre-conference knowledge, and after the post WhatsApp knowledge, again we will have another poll. No, it's loaded. He's just focusing it. The first question I have sent, all those who are in the WhatsApp group. Yeah.
Any way of putting the question there for us to also see?
Can we focus it from here? Audio visual. Just let me call the audio visual.
I think Dr. Pati has run out. Have you all got the questions? Hmm? No. Okay. Okay. Before you get the question, let me break the seriousness of the issue. Urodynamics is nothing complicated. Point number one. Point number two, you will either work in a hospital where there's a urodynamic lab with experienced technicians who have been doing it for years, which has got free access to anybody who wants to do it, in which case there is no problem. Or you'll be in a hospital where you have to start at de novo. If you have to start at de novo, then this kind of a symposium workshop is very useful. And don't worry, if you have to start, one of us will come and help you start. So here he is back, he'll take over.
They're coming to just put it on the screen. They're coming.
Okay. Shall we start with Dr. Ramesh and he can take forward the first talk? Hmm. Yeah.
Yes. Yeah.
Post lunch, they'll try to go to sleep also. The, so it's going to be now post session questionnaire basically. Yeah, put it up. Yeah. What a little mechanism for everything, man. Okay. Right, it's working. Um, so, like how Dr. Sujit Chaudhary has mentioned, urodynamics, it doesn't have to be exactly like the only machine based. It can start with the simplest step of home monitoring of bladder volumes and post-void residuals. It can be even before that, you can have a bladder diary. Bladder diary is the most important part of your before you do start urodynamics. Then you have non-invasive voiding phase studies like uroflowmetry. Then you have an ambulatory urodynamics, invasive urodynamics, video urodynamics, provocative urodynamics, and biofeedback. So the first step, you get a patient, you ask them to maintain a bladder diary, and then in the bladder diary, an ideal bladder diary should have been maintained for at least 1 week, but minimum 3 days. I want them to religiously maintain the time of voiding, then the volume of voiding, the child voided if possible, then preferably fluid intake, preferably the constipation and soiling. So much of it can be incorporated into a properly maintained voiding diary. And after maintaining the voiding diary, often people don't bring it back. So ask them to bring it back also. What is the point in maintaining it? So this is exactly what we have to do before starting even thinking about any urodynamics. You should understand that urodynamics is an invasive procedure. It's as serious as a voiding cystourethrogram or more serious, because you are infusing contrast, you are infusing, if you are doing video urodynamics, even otherwise you will probably be invading the urinary tract, which probably had a little bit of colonization, not necessarily in the upper tract, and then you are pushing it all up by infusing the solution. So you have to be absolutely sure that that study is needed. If you think that the patient has got a voiding dysfunction, what you need is a uroflow. That actually tells you the voiding flow. You can also have something called uroflow and an electromyogram, uroflow EMG. So this is a typical example of a voiding diary. Now let me give you an example. This is a 9-year-old child weighing 30 kilos. So the expected bladder capacity can be like 300 or 360. The formula for bladder capacity is to be age plus 2 times 30. And also there is a formula called age plus 1 times 30. Whatever you use, it is roughly around 300 ml. And the urine output is based on the weight and the 24 hours. So basically what happens is you get a bladder capacity is 300 ml, but daily output is 720. So you expect something like this. So in addition to the number of voids, ideal number of voids is morning 2 times, afternoon 2 times, evening 2 times or 3 times. And the night they are dry after they are 5 years old. So the night they don't have to wake up for this, because what happens is typically during the daytime the output is good. The early morning output is usually more, but the rest of the output is pretty much like uniform. And in the night, because of the antidiuretic hormone, they don't void. If they are not having bedwetting, they should not be waking up. But it doesn't actually happen like that. It sometimes happens like this, they during the school time they don't get to go, so they try to go a little bit more, little bit less, but usually it is like 7 to 8 times. So if it is something like the one which is you are seeing now, like 50 ml, 30 ml, 40 ml, it keeps on happening, then you know that there is a increased frequency. Anything more than 8 is an increased frequency. Then you can also express this maximal voided volume as a percentage of expected bladder capacity. So if it is less than 65% of the expected bladder capacity, then probably you can say it is low. ICCS definitions is important. More than 8 is increased frequency, less than 3 is decreased frequency. Nocturia is waking up in the night to void. It is not bedwetting. They wake up. Nocturnal polyuria is increased output more than the expected bladder capacity. Then it also can be like more than 20% of the urine output comes in the night. Now, as I said, uroflowmetry is something which is non-invasive, simple. It is very useful in children older than 4 years who can void on command. You should expect a bell-shaped curve, which is a normal curve. The bell can be one of these three. And the curve pattern and flow rate are something which we look at. The flow rate or Qmax is expressed as ml per second. And we have Euroflow nomograms. Why we had need nomograms? It varies with the age. Also, it varies with the voided volume. So if the voided volume is very less, then Euroflow is kind of not good. So this is a Euroflow of a real patient. I think that was a previous one was a picture. So this is a patient with a Euroflow which is bell shaped. But what has happened is here there is a bit of urgency here. The child has voided immediately. Okay, then the maximal flow is pretty high here, 20. Normal Qmax is like for 10 or something, or between 5 to 10. So here this is called a nomogram. This is Siroki nomogram, is volume versus the Qmax, and you can see it is way above the centiles here. So this child probably has got a high pressure voiding. So that is something which we need to know. So when you write or report a Euroflow, you need to write three things. One is the Qmax, other one is the volume voided, then the third thing is the PVR. So in that particular child, it is now what you have to note is here it's a bit like ECG. When you see ECG, the ECG gives multiple reports like heart blocks and all whatnot. So you have to read it. You can't read the print there. So here also the patient's Qmax is written as 21.3 because probably this patient coughed or moved at this point. So you probably have to look at it in that context of that curvature, and here probably the actual Qmax is like 17 and the volume voided is 180 and then the post void residual is 20. So this is usually done with a small ultrasound probe which is usually kept next to that Euroflow room, and you can look at it. So you can have a lot of useful information from just voiding diary and Euroflow alone. So these two are like the normal range are 10 to 12, and then in older children it can be little higher. And there is a relationship between Qmax and the total voided volume. Then there is a thing called Euroflow index, Qav by Qmax. So Qav is like the average flow. This is a Qmax. Usually it is half of it. So usually it is 0.5. Euroflow plus PVR is a simple tool to exclude obstructive uropathy. So meatal stenosis after a circumcision, meatal stenosis or a urethral stricture after hypospadias in an older child. I'm telling you older child. Again PUV, older child, a child comes with wetting at the age of 5. So you want to know whether there is a stricture, you start with the Euroflow. Then you can do an MCU if you need, and then if that also excludes, then you can go for why the child with the valve is having a persistent wetting or hydronephrosis. You want to know more about the bladder. So when you want to know about the bladder only, you go about the urodynamics. So the shape of the curves, it can be bell shaped, it can be irregular or staccato voiding, which is a feature of a detrusor sphincter dyssynergia. It can be an interrupted voiding, which means hypotonic bladder. Hypotonic bladder is typically like post sacral agenesis or one of those conditions, pull through procedures where completely the bladder is innervation both, and it can be a lazy bladder, it's a late stage of valve bladder. So atonic bladder, it can be like that, or it can be prolonged flat curve, which can be feature of obstruction. Less than 10 is usually suspected as an obstruction. So we can see that this is a normal curve, and this is an intermittent curve, and this particular curve is that of a staccato voiding. Staccato voiding means it kind of interrupted, and then there is a increased activity in the EMG. So this electromyography are basically like ECG leads placed around the NS canal in the perineum. So they are basically you're looking for skeletal muscle, external sphincter dyssynergia. It is not an internal sphincter. You are measuring the external sphincter dyssynergia. So what happens is typically when the child voids, there is a contraction. So this is the same thing which causes the spinning top urethra. So that is a way of representing it in a curve here. Then the intermittent flow is totally different thing. Intermittent flow is a feature of an atonic bladder or a completely not contracting bladder where the abdominal muscle contracts. So you strain and valsalva voiding. That is an intermittent flow. This is different from a staccato flow because a staccato flow does not reach the baseline. Then we have this stricture like pattern also. So this is a Euroflow EMG which is being done there. As I said, you have to look at it in the context of where it is. Now we have looked at that Euroflow abnormalities and how that can be useful in evaluation of children with the lower urinary tract dysfunction. We found out that a big group of them had a dysfunctional voiding, which means they have a staccato curve with an active pelvic floor and normal voided volume. We have some children with idiopathic overactivity where there is a shortened trace you saw earlier, quiet pelvic floor, there is no external sphincter dyssynergia here, and reduced voided volume. They cannot hold urine, so they keep on emptying the bladder. Then detrusor underutilization. This is pretty much like your late stage of valve bladder where there is a prolonged flat trace. Pelvic floor, there is no contraction, and there is a large voided volume. So there can be 3 different patterns. Just based on your Euroflow alone, you can tell all this information. I won't go into these medical management and all. No, this is another overactive bladder index which we have proposed, and then I also don't want to complicate things here because this is much beyond what we are going to talk. Now, coming to invasive urodynamic test, it is typically performed in children with myelomeningocele or after pelvic surgery, or in posturethral valve with persistent hydroureteronephrosis even after the valve is gone, or intractable bladder dysfunction. Intractable bladder dysfunction means somebody who does not have any obstruction or neuropathy, but they still keep on having this hydroureteronephrosis. So they develop, they go towards the Hinman syndrome or non-neurogenic bladder. You still may are justified in using urodynamics. Then upper tract changes are there. But when we usually do not ask for urodynamics is when the child has got bedwetting. That is purely like not a problem of the detrusor. It is a problem of the cortical centers. So and the ADH problem, the SIADH kind of situation is there. So that we don't want a urodynamics. Then when you have the clear-cut voiding dysfunction like a spinning top urethra, and then you've already diagnosed an overactive bladder, you don't need a urodynamics if you don't have any upper tract change. Then in children with the classical VUR and no bowel bladder dysfunction, normal voiding, the bladder contour looks over normal. I mean, here also, if the bladder is absolutely looking normal, then I prefer not to do urodynamics. But if the bladder looks abnormal, or if the child has got some symptoms or thickening or something, then we go for urodynamics. So a study that does not duplicate patient symptom is not diagnostic. Failure to diagnose an abnormality does not rule out its existence, and not all abnormalities detected are clinically significant. So that is about urodynamics. Video urodynamics. When do you need a video urodynamics? When you have a gross VUR. What happens is you are filling the upper tract. So when you are filling the upper tract, you are having a spuriously normal or false normal urodynamics. So you have asked to report this urodynamics. This report looks absolutely normal, but it doesn't add up. That's because you are filling the upper tract. So when you do your video urodynamics, you know when the reflux starts. So that is actually the functional volume. The functional bladder capacity is when the urine starts going upwards. Or the other thing is leak. When a child has got bladder neck incontinence, the child typically who has undergone either the sacrococcygeal teratoma, for example, all nerves are gone, or some pull-through procedure, abdominal perineal pull-through, where everything is gone, they may have a sphincter problem and a bladder problem. So you do not know whether it is the leak due to the sphincter or the bladder. Then when you do video urodynamics, you can get what is called a abdominal leak point pressure or a Valsalva leak point pressure. So you know when the detrusor pressure goes up, then that is the detrusor responsible for the leak. Whereas if the patient is straining, then you know that it is the other way of doing it. Now, preparation, we have to get informed consent. Urine culture should be negative. Bowel should be well prepared. Always get a natural uroflow. Now, after doing a urodynamics in a child, it is very difficult to make them void. So I always ask them to pass urine upfront in a uroflow machine and then go for a urodynamics. The differences between a younger child and an older child or an adult or other patient is like in a little child you may have to do in a lying position. In an older child, you can record the leak in the beaker. So there's a beaker, they sit on that. Whereas in a little child, you have to see. Then the fill capacity has to be low. They cannot tell the sensation. So the first sensation is when they start crying, or when they are already crying means you can't tell. Then they do not void on will. So you cannot get a voiding phase. In an adult or an older child, you can get a voiding phase, which is very important, particularly in a child with an atonic bladder. So that's about it. And I will stop here because there's much more to talk about. But because of lack of time, we are going to see a live demo of urodynamics. So we will tell you about how to set zeros, how to calibrate the transducers, how to establish the reference levels, and what is the quality control. All those things will be actually showing you. So that is important for you to know when you see it practically. All right, I'll stop here.
Dr. Ramesh,
Yeah.
you want to sit there and answer the questions?
Yes.
You want to stand here? Thank you, Dr. Ramesh. I see in this hall there are two categories of people. One, who are highly experienced pediatric surgeons, and second, those who may be starting their career in pediatric surgery. Now, are there any questions that you would like to ask, or you would want me to ask Dr. Ramesh a few questions and let him answer? Any questions from the audience? Yeah.
Voiding is associated with high pressures. Just you mentioned that the bulk gave the child started with urgency. So can we tell on just on the basis of uroflowmetry curve that the child is having a high bladder voiding pressure?
Yeah. So, as I said, you should have a working diagnosis upfront. So if you are talking about a neurogenic bladder or one of those, it's a different story. You need a voiding phase to know the Pdet max. That's what you call. When at the time of voiding, what is the pressure? But in a little child with classical voiding dysfunction, I'm able to, with no upper tract change, I'm okay to start them on anticholinergic without a filling phase study because I know that upper tracts are not dilated. But whereas in a child who has got a spina bifida or myelomeningocele operated, my approach will be to do a urodynamics because I need to really know like what you have said. Okay.
One more thing is I think you also wanted to ask that just by looking at Euroflow whether we can predict the pressure. Is it something like that? So it is at times possible if it's a very steep tower type curve and there is no apparent obstruction, we consider that it's a high pressure. I mean the Pdet max will be very high. Just seeing the Euroflow.
Okay. I think let me ask you a few frequently asked questions by which you will be able to transmit the absolute essentials that to be known before we move to the next step. You know, if I'm a pediatric surgeon working in, for example, Odisha's context in Sambalpur, I am a surgeon who has got a very good reputation. I look after my patients well. I also know who all need urodynamics. But there is no urodynamic machine. The patient will have to travel several hundred miles to go to Bhubaneswar. First, what I want to know from you, sir, is for how many months or how many years is my patient safe after birth before he begins to get irreversible kidney damage and I must send the patient off at any cost for urodynamic study? Are you able to give some idea?
No, that is a pretty loaded question actually. See, I consider it like this. If you are going to do anything more than medical management, like for example a Botox, you think that the candidate is for a Botox, or if it is a candidate who might benefit from augment because the upper tracts are very much deteriorating, then I would at any cost get a urodynamics wherever they need to go because at this day and age, I think getting at least a baseline urodynamics is a must. On the other hand, if I have a patient with the posterior urethral valve, it's a common situation. I'm following up regularly. They are already on anticholinergics, and I may not push them towards a long distance.
Thank you. Okay, let me give you the straight answer to this question. There is no way of managing a child well without urodynamics if they need it. Number one. Number two, the only period in life when you can say the baby does not need urodynamics or we may not really need it urgently is the first year of life. For example, you have treated a PUV at newborn or 3 months. You can allow 6 months or 12 months for the effects of obstruction to get spontaneously better. But in general, a urodynamic study at 1 year of age and 5 year of age is a basic requirement in any child who needs it. Would you both, all three of you agree with that? Okay. So I think this is one take home, that if urodynamic is indicated based on the usual teachings that you have had or based on the usual picture or theoretical knowledge, a urodynamic study at 1 year and 5 year is what we should aim for. Second, uroflowmetry is not the substitute for cystometry. Do not try to derive more information than what is possible to derive from a particular test. So uroflowmetry can give you no idea of detrusor pressures. Third is starting anticholinergics, sir, without any urodynamic study is forgivable probably in the first few months or first few weeks after removing or ablating the valves. But starting anticholinergics without urodynamic study, you are going to make it difficult for the urodynamic study to become reliable while on anticholinergics. Okay. Third thing is, Dr. Ramesh.
One point to be added here: starting and even stopping. I'll have a case.
Yes. Dr. Ramesh, I am a pediatric surgeon. What should I tell the patient before sending it to you for urodynamic study? How will he be prepared? What sedation will he require or no sedation? Will it be painful? Does it have risks? Does it have risk of creating UTI, fulminant UTI? And approximately how much does it cost in an average private hospital? Just a rough idea.
Yeah. So I have to be frank here, right? And you are the referring pediatrician. So I have to tell you there is a definite risk of the child going into urosepsis. So you please make sure that the child has got a negative culture before sending. If you are not getting it, I'm going to get it before that. Then also, if I'm going to give some aminoglycosides, I will even want a creatinine because I don't want to precipitate a CKD or AKD on a CKD. Now, about the invasiveness, it is invasive. It is going to be painful, and the child is definitely going to scream the head off. We cannot do it under anesthesia, and sedation maybe, but it's not done usually under sedation. A little bit of sedation, it's okay, but definitely not anesthesia for urodynamics. Then the cost varies between a trust hospital and a private hospital. It's a huge range from 4,000 to 15,000. Total cost, I mean about the test as well as that machine cost, running cost, medicines, then various consumables like these rectal tubes and all cost a fortune. Some people reuse a rectal balloon, some people just do custom made rectal balloon. So it depends on what you do. That can be less if you use a custom made rectal balloon. Even reusing of that urethral WM and catheters, they can impact the cost. It can be much less. So the patient has to be counseled accordingly, but it is definitely a stressful procedure for both the child and the parent.
So the reason I asked this question is the risk of refractory UTI is real. I mean, I wish Dr. Narasimhan was here. He went on academic leave to England. I had just come back. He handed over a baby to me. Very nicely ablated PUV baby, repeated UTIs. And I, having trained overseas in my enthusiasm, said this baby needs urodynamic. That baby got refractory UTI. I was in a government hospital. The family came back to tell me the baby passed away in peace at night. So urosepsis can be very, very dangerous in small babies, and that is why earlier than 12 months in a baby who has got obstruction at multiple levels, posterior urethra, bladder neck, neuropathic bladder, VU junction obstruction, do not rush into urodynamics very early unless it's necessary. Second, you have sent a baby from a remote town to a bigger city. Urodynamic study has got done. If the baby came back with UTI, it is not the fault of the operator. It's a risk that is there, just like MCU in urodynamics.
I have to tell you, it is not just urodynamics, even your MCU for that matter. You leave the contrast, you find that there is some issue or no issue, but the child did not void. You do not empty the contrast, the child becomes acutely septic, and then they can rapidly deteriorate within 24 hours. Take it from me. Last month only we had a patient. I feel so sad to send the patient to check for after posterior urethral valve. The child was doing okay. And at the age of 2, I asked for a repeat voiding cystourethrogram. Somebody didn't empty the bladder. The child passed away within 24 hours.
There you are. Okay. Third thing, sir, I want to hear from you. Is it painful?
It is distressing.
It is very distressing in a awake child. Mind you, the family will come back to tell you that I did not have so much of pain in the actual cystoscopy or incision of valve as much as I had in the MCU or urodynamic study. So then what is the solution? The solution, as he said, a mild sedation with propofol takes care of things, or the child be given time to do it. And as Dr. Subhashis has been telling in many of the symposium and workshops, this is not something which you can be quickly coming in 5 minutes doing and getting out. You are either into this game or you're not into this game. And if you're into this game, then keep an afternoon in a week to do this work which you love doing, enjoy doing, and probably will be able to do 1 or 2 studies in a half a day. Is that okay?
In fact, just one point needs often a second cycle gives a different result. So it's
Yeah.
always a good idea to
Yes.
do. So
Yes.
I mean, you should have enough time in hand. That's
Yeah.
And do not refer a patient for somebody else to do a urodynamics if you have a machine. You have to be there. Don't just be an interpreter, because you're not a radiologist sitting in one AC room and interpreting. You have to be with the child, talk to the child, talk to the parents, see every trace, because they might not have noticed the events. The events you see when the child starts leaking is actually the capacity, not what they filled. The child probably had 10 leaks before, and you never knew that that was the actual capacity. You think that her 200 ml is gone, but the child started leaking at 50.
So I think from a practical standpoint, if your child was going to another city, then the family have to know that they may have to stay for more than 1 day to get it done and come back. Or if you are doing it, it is better to tell the family that you are going to do this urodynamic study and they should be prepared to stay for 2-3 days to make sure that there is no infection before they go back to their hometown. That's very important. Are we all clear with whatever Dr. Ramesh Babu shared in the slides?
There is still a lot left in the calibrations and pressure settings, which we'll see practically.
So practically we will be going through everything. If you all are happy with whatever he has discussed, we'll move to the next talk. Dr. Subhashish, will you be taking up the next? Thanks.
what's happening? Yeah. Should we start? Yeah. So, good afternoon, everyone. So, we have already learned from the last Professor Ramesh Babu what are the basic things when you are planning a aerodynamic study. So, I would like to stress exactly on in real situation what are the things which many people miss and which may actually influence your understanding and your deciphering the tracings. So the first is the history is very important. I mean, you just can't start doing aerodynamic study on a child. So you have to be very clear. So this is what we call the aerodynamic question. That means the moment you are going to do aerodynamics on a baby, you have to be very clear in mind what we are exactly trying to know. What are the points which we will note in this particular baby? It varies from child to child. So we have to have a very clear note of the history, the clinical presentation, the investigation, basic imaging, and voiding diary. This is without voiding diary, you can't simply do a urodynamic study, because we need to know what is the functional bladder capacity of the child, and a voiding diary gives you the closest approximate of what the capacity of the bladder looks like for that child. Accordingly, you will titrate your filling of the bladder to that volume. Second is, what is the position of the patient? Like as Dr. Ramesh Babu said, that below 5 years and above 5 years. Now, when in a child, you are doing a urodynamics in a 1-year child, so is there any way how we can note the flow also? You can modify. So we have modified our table. We have cut in the middle, a circular cut, and we place the child in a fashion that the child voids into that cut, and we keep this bucket which you find here just below that cut. So even in a child, when you are doing it in a supine position, you can have a uroflow. So that is possible. And same child, you are doing it in a sitting position, you often repeat the child, same child sitting and standing, I mean standing and sitting and lying down. So the curve differs. Gravity helps in drainage. So there are a lot of issues. So whether the child, while you are reporting the tracing, you need to know the child was in a lying down position or sitting position. Second is, what is the range of volume? The same curve of the uroflowmetry of a child can become a bell-shaped curve from a plateau curve just by changing the range of study. So the range usually we keep is 0 to 100. Now if we change it to 0 to 20, immediately the same plateau curve will look like a bell-shaped curve. So it's very important. I'll show you in that curve, I mean what exactly we need to know. And rectal catheter, whether it is there or not, number one. Number two is, there are many centers who do it without rectal catheter. There are a lot of problems with that. And the bowel should be clear, because with the stool inside, the tracing will be different. And of course, repeated confirmation by cuffing, whether they are cancelling out, the abdomen, pre-abdomen and pre-detritus are cancelling each out, or the catheter has been displaced. To know that, you have to do repeated cuffing maneuver throughout the studies. So now coming to the, now if you look carefully at this particular curve, you will find that there is a continuous, this thing. So it is significant. Now apparently it looks like there is a lot of overactivity, a lot of things going on, but this is a normal curve, I tell you. The reason, if you look at the curve second, is there any pointer? So if pointer please. So in the second one from above, that is the rectal catheter. The reason why there are so many positive deflections are, the rectum is loaded with stool. Now this particular child, which is leading to the, okay. So these negative deflections are a result of this. So these are all these are due to the stool. The flow is hurting the stool, and every time it's creating a deflection. This is a normal study, but looking like abnormal. Now you have to know very clearly which drugs the baby is on, as sir was discussing just now. Now this is a PUV child, 3-year child. We had fulgurated in the infancy, was very stable with tropan. He was on tropan. So we were very happy with this particular curve, this one. So we stopped anticholinergic. Now the child comes back with symptoms 6 months later, and when we repeat, this is the curve. So it's again going back to a overactivity and loss of compliance. So basically, when you are starting anticholinergics, you need a baseline curve. That what is the status of the bladder exactly when you are starting, and even when we are stopping, you have to have a close follow-up. And whenever you feel that there are symptoms, you have to repeat it to know whether you have to restart the anticholinergics. Now I'll just rush through a few case scenarios. Now this is a child, this is an 8-year-old girl, now consulting various doctors for bedwetting for last 1 year onset. Now bedwetting started at 7 years after being dry for almost 3 years. So she has occasional wetting of pan, and there are plenty of documented UTI episodes, 3 episodes. Now there is a associated with straining to void, sense of incomplete voiding, nocturnal enuresis, no hematuria, dysuria, flank pain, cannot hold urine once she has the urge, immediately she has to pass. And mother often finds her undergarments soaked. Now, negative are neurologically she's fine, no sign of sexual abuse, no palpable bladder or kidneys, but rectum is loaded. So this is the MCUG. Now it's anybody's call. I mean, we know that this is a spin top bladder and this is the UDS. Now here, if you look carefully, this is what Dr. Ramesh Babu was saying, that if you use EMG, EMG is there are difficulties in using EMG, but it is always helpful, particularly if we have the symptomatology suggests that it's a DSD. So this is you can find at the height of this is only the voiding curve. So during the voids, he is generating high pressures repeatedly, and all those time, this EMG is going up. So this is clearly a case of detrusor sphincter dyssynergy. Now this is another child with a very poor urinary flow. That was a female child. This is a male child. Once again, a similar thing. There is a staccato void and there is a excessive bladder activity. And this is a MCU which is showing no void, very thin urinary stream. Now this is another child of the same similar finding. Now PUV. Now I won't give you the history. I mean just the various spectrum. So PUV can come with a lot of variations. And it may be a normal bladder, absolutely not. That is the reason why we need a baseline UDS assessment of most PUV patients, even if they are symptomatically good, if you have a good setup for urodynamics. So at 1 year, if we have this sort of finding and the child is not on any drugs, these are we call overactivity. Why? Because here it's coming back to the baseline. The baseline is static. So the compliance is normal, but there are episodes of overactivity. This child will definitely need anticholinergics. Now, this is a situation in a PUV child where there is a high voiding pressure, but the flow is very low. Now, this is a situation which we often face. Now, this could be due to residual obstruction. This can be due to this is due to residual. Now, there are two scenarios. One is the void is poor because there is myogenic failure. You have used tropan for too long, so the entire muscle is inactive. And there may be situations that the voiding is child is generating high pressure, but the flow is less. So this is a situation where the pressure generated is pretty high, 45 is going up to 60, but the flow is low. So these are situations we have to adjust accordingly. This child will benefit from a check cystoscopy and maybe some other maneuvers. So this is a poor compliance. Here you see this is the entire curve, entire UDS curve, and you see the baseline is going up. And these are the situations actually where we have asked the child to cuff. So we have to see that the cancellation is good. If this doesn't correspond with this, then we know that the catheter is not in place. So this is what I was telling. Repeatedly you have to do cuff. You asked the child to cuff, or now in a small child who doesn't obey you, he doesn't cuff. What do you do? Anybody from the hall? Yeah? Cry. Child is not crying. Child is peaceful. Anything else? You can just apply a suprapubic pressure with your hand. That is equivalent to cuffing. So that will cancel. That will cause a deflection on both sides. Yeah. It's going up. It has come down. There is leak here. It is leaking. Yeah. So you have to take everything together. Yeah. Volume. It'll again go up. Yeah.
You see, he's asked a very pertinent question, because in a dangerous bladder, in a patient who actually may need even surgical intervention, you may completely fail to show high pressure.
Yeah.
And quite often you will have adult urologists come and write that this doesn't require any intervention, whereas actually his child is sitting on a time bomb. And what is happening is that he's constantly leaking when the urodynamic study is going on.
Yeah.
So failure to show high detrusor pressures is very common and is the most dangerous segment.
Yeah.
So this is not pressure going down or low volume. This is pressure leaking.
These are the points where she has leaked. And mind you, these marks I have put. So it's not like machine will put it. So this is the reason why you have to be actively involved during the study. Entire thing you have to sit by the bedside. Whenever it leaks, you have to put a mark. So only then you can later on. And these pressures, these are also not automatically generated. All these pressures you have to ask the machine. You have to click a point where the pressure will be generated there. So after that, when you are doing a reporting in the evening, then you have all this data in. You can, if you just go on doing UDS, nothing will be there. It's a blank sheet with just the curve. You won't be having any data.
But I have to point out a couple of things here.
The point.
So this is a very good graph, which I want you to note down a few points. See here, the pressure is at around some 8 or something, and here also it is at 8, and this is 0. So these two are called resting pressures. Our bladder has got some pressure, 10 to 20 pressure is there. It's in the stomach, anywhere inside the abdomen. So it is not 0 minus 0 minus 0 is 0, but 10 minus 10 is 0. So that is something which you have to remember, and that is a good subtraction. And each time the child is coughing, the subtraction is good. So we actually started at 0 here when we started the study, or before we started the study. So that is something which you need to remember. The second point is here it is 100. So you may wonder why this slope is not like this. It all depends on how compressed your ECG is, or how compressed your this thing is. So during actual running of the study, you may not feel the rise of pressure, but when you print it out, you will see that it is going up rapidly. If this is 50, then you probably will see that this is rapidly going up. So you need to know what are these points, where you started, where you ended, all those things you need to know.
So this I was telling you in the beginning, that if I lower the range, a plateau curve will look like a steep curve. So I mean, the shape of the curve, you have to look at every point. All these things need proper. So this is a normal voiding pressure but low flow. This is once again a normal voiding pressure with a very low flow. This can be due to a lot of reasons. Once again, if whether there is myogenic failure or there is outlet obstruction. So what could be the possibilities? Now see. So this is the filling phase, and this is the voiding phase. Voiding phase is almost 4.9, 2.4. It's so this is clear cut. There is an obstruction here. So if it's a myogenic failure, you stop the anticholinergics. If there is a polyuria, even polyuria can cause myogenic failure. In especially PUV patients, end stage CKD patients, there's a huge amount of urine being produced. So these children benefit a lot from nighttime drainage. Just 12 hours, if you drain this thing, the muscle, myogenic failure gradually sometimes improves. So now we come to neurogenic bladder. This is a 3-year-old child, follow-up of lumbar meningomyelocele, operated at birth. There is bilateral lower limb weakness, dribbled urine continuously till to 2 years of age. Now passes small amount of urine on cues. When you just utter a sound, he will pass, and remains dry for 20 to 30 minutes, dribbles continuously at night, recurrent UTI. DMSA shows bilateral scar. This is the MCU. So herein, apparently the bladder looks good, but there is reflux. So in a neurogenic bladder, if there is a reflux, so surgical fixation of the reflux is not the first priority. Always we have to keep in mind that there is a possibility that it's a secondary reflux due to detrusor overactivity. So the point is here, is invasive UDS necessary? So the question answer may vary from point to point, but we believe that it's necessary. So there are options. We can just start off CIC and see whether the reflux reduces. That's one way of going about it. The other way is we directly go for the invasive UDS. It shows significantly bad, the bladder, which is kidneys, which are in a very great danger. Because you see, with 130 ml of fluid, there is a leakage here, but it's going up to 35 with only 138 ml of filling. And now with 168 ml of fluid, it's crossing 40. So this is definitely a dangerous bladder, high risk neurogenic bladder. After management, we use tolterodine, we use CIC, bowel management. So leakage continued. Now 4 years now, 1 year has passed. So this is the volume has increased per CIC volume has. Now this is the curve. It's much better. It's almost stable. So this is how you actually monitor, because This you can do it on guesses, but guesswork, it is always better to document what you are dealing with. Every medical intervention needs a documentation, why the science behind why you have used this medicine. And it's better to be clear to the parents also. Now this is now the bladder, the reflux has completely subsided. So this is another, I think I'll just, because of lack of time, we'll proceed. This is another actually very bad bladder. Now this was the MCU. Once again, it shows pressure going up, shooting up like anything. I mean, only with 17 ml volume, pressure is reaching 74 centimeters, which is 3 months later with anticholinergics. Now from 74, it has come to 41, 23 like that. And this is a MCU has also partly improved. And 2 years later, now it's at baseline. So this continuing evaluation. Now in neurogenic bladder, we always say that continuing evaluation is needed. Just not that you get one UDS for life, not that. Because you have to titrate accordingly your medications. So in extrophy, it's very important. Now extrophy, now we are coming up with our IAP, Indian IAPS stalwarts. We are next issue it will come. What is the experience of extrophy? Now here also it's very important that we just do not rely on the of course, clinics is important, history is important. This is one of the extrophy, closed extrophy patients, 5-year male child, but there is continuous dribbling. This child presented to us with just continuous dribbling when awake and no leakage during sleep. And this is the curve. You can see episodes of overactivity. Here, 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 here. And this was abdominal point pressure was pretty high, sky high, 55. So this child improved well with this thing. So I will end with this particular child. This is a child with urogenital sinus, and basically there was a superior vesical pressure which was close somewhere. The child came to us with see the uroflowmetry. This entire during the entire flow sphincter was just tight like this. So we did a suprapubic. We did a Mitrofanov, and everything was settled. Now this child, what they did, since the child was doing very well and was at times voiding from the native urethra, parents were very happy. They stopped anticholinergics, they stopped CIC through the Mitrofanov, and ultimately the Mitrofanov closed. It didn't close, it was spastic like this. So it was not going. So when we repeated the urodynamic study, it was very high. It went up like this. So it needed again anticholinergics, again starting that thing. The spasm went down and it could be catheterized. So even a Mitrofanov, if it cannot be catheterized, could be due to high pressure of the detrusor, due to highly active detrusor. Even that simple thing, just with anticholinergics, but you have to prove what is going wrong. So this is in urodynamic study is actually a tool in the hands of the pediatric surgeons, and that is actually very helpful. Thank you.
Questions?
Are you going to demonstrate anything further? A few things. Okay. I think you have very nicely demonstrated some cases. Any questions from the audience or observation?
Please.
Yeah. Feel free. Feel free. There's no dearth of time.
Any doubts, anything? Pressures are standard treatment.
No, can I take that question? So you're talking about dysfunctional voider with detrusor sphincter dysenergia or something else? Sphincter overactivity. So usually it is associated with bowel bladder dysfunction. You have to treat the bowel dysfunction first, and if that is completely cured, then you have to go for biofeedback. Biofeedback is a way of learning to relax the sphincter or unlearning the bad habits of contracting the sphincter. So that has to be, that's called urotherapy abroad. But here we have to sit with them on a session. It's usually possible only in an older child who can be taught. But with the biofeedback machines we have, many centers don't have, but you can actually, they show pictorially. So to relax the muscle, the fish opens the mouth and eats the worm like that. So they can open it with the help of some images and stuff. I don't know whether this machine has got biofeedback. It has. So you'll be seeing a biofeedback also demo later on if you want.
See, technically, the case that he demonstrated, the first question you need to ask is that MCU from a girl or from a boy? And if that MCU is from a girl, a non-invasive test like a Euroflow with ECG, AMG monitoring will clinch the diagnosis as dysfunctional voiding. Then comes the question, how do I demonstrate whether this is a high pressure bladder or low pressure bladder or a normal pressure bladder? In general, these are all high pressure bladders. If you can have the facility of urodynamic, you should do it, because then you will be able to prove what treatment you are doing. Because the case that he demonstrated is a pretty refractory case and is not going to respond to gentle urotherapy in the first few weeks. So probably a couple of weeks or months of anticholinergic is reasonable. These are very tough cases to treat because surgery is not the first step of treatment. Sometimes you may even need to use Botox in these cases.
This child improved with intrasphincteric Botox.
So if your question is, how do I treat? The answer is step ladder protocol, the way you treat blood pressure. And the first intervention is what Dr. Ramesh Babu said: psychotherapy, treatment of constipation, treatment of high bladder outlet pressure, which is use of gentle dose of alpha blocker. If bladder urotherapy, relief of constipation, mild pharmacological manipulation does not work, then you can step up the treatment to Botox, injection in the bladder muscle, and injection in the bladder neck, and injection in the bladder sphincter complex. And in rare cases, you may even have to proceed to intermittent cath. If that did not work, you may even have to proceed to forcible dilatation of the bladder neck and sphincter to destroy some of the fibers. And I don't know whether you may recollect 2009 editorial Journal of Pediatric Urology. His boss wrote the editorial that some of these cases may even need progress to augmentation, otherwise they lose their kidney. Yes. Yeah. Okay. So he
Now,
has
one more
shown
point I want to, ask or convey. Now, Manoj was asking whether there is any medication for this sphincter problem. Now, the sphincter we are talking about in PUV is totally different. There, the bladder neck and sphincter are responsive to your alpha blockers. Whereas in female children, you're talking about this BBD group, we are talking about an external sphincter, and we do not have any targeted skeletal muscle relaxants. So that is why we are talking about Botox.
I think they have discussed good variety of cases. And are we going to practically demonstrate?
Practically, it was originally a
Okay.
small
Uh,
segment, 20 people. We have many.
Doesn't matter. Everybody can see. The basic principle is, see,
Privacy
okay,
is
two main groups of urodynamic study. One is the conventional cystometry. Second is the video urodynamics. Video urodynamics is nothing but adding a little contrast in the installation fluid with facility to do image intensifier. So if you had the gadgetry to do a modern video aerodynamics, that's great. Otherwise, you can just wheel the machine into a fluoroscopy room and you can get video aerodynamics. So I think demonstrate a little bit, at least the parts of the machine and the connections, and the tubings and the transducers.
This thing there, you will see the curve here. Like that?
Fantastic.
That is good.
Fantastic.
That is nothing.
So Dr. Pati will demonstrate actual urodynamic study being done. Yeah.
Before that, I would like to add parts of the before we prepare the patient. Let us have a demonstration about the parts of the instrument and other consumables. Please come, Kundan.
Hello. So the system which is here is manufactured by Cryomedical Spain and installed and supplied by Hospimedica company. The model name is Hermes, and you can see here all the parts has been installed in the card only. The control panel of the equipment is inside this box, and this is all-in-one PC which is connected with the control unit. And you can see here it is a wireless EMG device which is supplied to take the EMG data in Euroflowmetry, either Euroflowmetry, yeah, you can use it in Urodynamic system. Here is a Euroflow sensor, which is a wireless Euroflow sensor. I can show you. So it is a battery operated Euroflow sensor. And these are the consumables which will be used during the urodynamic recording. So here is a 2-lumen catheter, sorry, this one. So this one is a 6 French 2-lumen catheter which is used for child. This one is a 8 French 2-lumen catheter which can be used for adult patient. This is a balloon catheter which is used for abdominal pressure recording. This is the tubing set for infusion pump. This is a tubing set which can be connected to the catheter. And if you are recording the EMG, so where is the patch electrode? You can use this patch electrode for the recording of EMG. So these are the consumables parts which is used during the UDS study.
Can we stop here and can I ask you some basic questions?
Right, sir.
So the urethral catheter which goes into the urinary bladder, you have said is 6 French.
Yeah. This one is a 8 French, sir. This one is a 6 French.
So it's brilliant. You have got 6 French and 8 French.
Right, sir.
Now please tell me for the benefit of audience, if I have a 1-year-old child, what will I use? Double lumen catheter. And where will I use the 8 French?
So basically, two things needed to be remembered. You can just handle this thing. Now, this particular catheter is a little stiffer catheter. That is something we have to keep in mind. Suppose I have a PUV patient whose bladder neck is very much prominent. So there is a possibility that I might not be able to push in this catheter. This is a little stiffer compared to an infant feeding tube. So in such a situation, we have another option. Suppose this doesn't, I'm unable. So whenever pushing this catheter, UDS catheter, we have to put in a lot of jelly. So you have to lubricate it properly, allow some time, and then gently push it. If it fails, then the option is you can use 2 5 French infant feeding tubes. Infant feeding tubes are little less stiff. So you can use 2 infant feeding tubes. One is connected to the transducer, the other is connected to this thing. This single double lumen is replaced by 2 single lumen infant feeding tube. Now 6 and 8. Now suppose below 3 years, below 4 years, not 3, we always use 6. Above 4 years, we use 8. That's our usual protocol. But nowadays, we have one published paper that just whether this presence of catheter in the urethra creates some amount of obstruction which is reflected on the urodynamics curve. So now even up to 7-8 years, we try to use a 6 French catheter. That gives a better outcome. This error component is reduced if we use a 6 French.
Whether Sujit will remember this. In the UK, we used to put a suprapubic lines to overcome this problem. So we used to make a puncture and then leave either 2 feeding tubes or 1 double lumen catheter and then do it the next day. So that way the urethra is free to void. It is not partly obstructed. Now, two tubes have come to you. Has anyone has got any questions about these tubes? So one is a W-lumen catheter. I think that W-lumen W-lumen, the one with the two lumens at the end, is the urodynamic, where there is a filling line and then voiding, that bladder pressure and that sorry, one is a filling line, other one is a bladder pressure. Then the one with the balloon is the rectal line. Okay, so there are two catheters inserted, one in the rectum, the balloon, one with the balloon is inserted in the rectum, and the W-lumen is in the bladder. Now here you have to understand that there is a lot of errors and artifacts that can happen, which you can actually correct it only when you are there in the room. For example, if there is an air bubble in one of those lumens, if it is in the filling, the W-lumen catheter, if it is in the filling, then the filling will clear that. But if it is in the where you measure the detrusor, the vesical pressure, it will give you a false reading. Similarly, this is a transducer here. So this transducer also has to be completely filled from below, and then it should be emptied of all air bubbles. If there is any air bubble, you will not have a proper recording. I mean, that reflections will not be there. Now, one important point I want to make you to remember when you are in the room watching the urodynamics, the trace, you see the three traces, right? These traces in a live patient should be moving. It is never static. If it is showing 10 static, then that is not right. 10, 11, 10, 11, 10, 12, 12, 13, 13, because it's reflecting every breath, every moment, everything is reflected in that bladder. So that means there is no air bubble. If it is not moving and if it is just a flat line, even at higher pressure at flat line, that means there is an air bubble in the system. So that you have to be absolutely careful. Then the rectal pressure, the rectal catheter has got again a rectal balloon and another lumen there. So that is to inflate your balloon if needed. So that is again an optional thing, because sometimes the rectal balloon, if it is overfilled, you will have a negative deflection in the detrusor pressure, because the rectal pressure is more than the vesical pressure. Then the detrusor pressure will start at minus, and then if it starts at minus and then you just zero it before even zero all, you give zero all, what happens is the detrusor pressure is running below the floor. So you won't know, it probably has come already up to here because you started at minus and zeroed it at minus. That is when things go wrong. Is that right?
And two more basic points, practical points is, often it happens that we have started the study, the bladder catheter is not showing anything, it's blank, it's not showing any curve, anything. That sometimes happen because the tip of the catheter is just sticking to the bladder wall. So that automatically improves just after 20-30 ml of filling. Then it suddenly shows curve. That's a basic, I mean, that sometimes confuses people. There is no curve, whether it is displaced or something, it's nothing. In an empty bladder, absolutely empty bladder, sometimes it doesn't record any curve. Second is rectal catheter one, which you are seeing now, is actually very costly and it often gets damaged. So replacing that becomes a lot of headache and a lot of cost becomes involved. So what nowadays for last 3-4 years we are using is, we are using a 6 French feeding tube with a gloved finger. We just cut a finger of the gloves and attach it. That gives a fantastic result. All these curves you saw now are using the rectal catheter, using a 6 French infant feeding tube with the gloves.
Six French double lumen tube and 8 French double lumen tube, because I want to start a new lab. I want to know the average price of all these consumables. Okay, so roughly 2,500 is the price of these double lumen catheters
for 10 cases.
versus 100 rupees for two 6 French catheters, two 5 French catheters. 100 rupees versus 2,500 rupees. So in an older child, for example, 8-year-old child, perfectly okay to use two 5 French feeding tube.
Good result, fantastic.
Okay. Want to go a step further, the nearest tube that we have in our practice, which is not known to the urologist, is an umbilical catheter. An umbilical catheter is the softest traumatic catheter built for newborn babies and premature babies. And it's quite often 4 French, 3 French. So 4 French, 2 umbilical catheters are absolutely atraumatic, cheapest way of doing invasive urodynamics in India. Second, rectal catheter. My child is 6-year-old. In any case, he is traumatized with multiple tubes going in the urethra, anus, perineum. What mandatory situations are there to have a rectal catheter? Or can I subtract randomly 5 or 10 centimeters of water and prevent that trauma to the child?
Rectal catheter is purely optional, provided you can guarantee a completely empty rectum, because that affects the bladder function. So if you are very sure, and whatever you are thinking, the cystometry reflects that, you are not in confusion, it's okay, we can. And number two is very important, is this particular catheter, if you are doing a video UDS, is very important, and what I'm going to say now, because we have suffered a lot. The moment you put contrast in this catheter, is going to be damaged sooner. Suppose I was saying that with one catheter we do 10 cases. If you use contrast, you can do it in 2 cases. After that third case, it will be damaged. That's point number one. Point number two is, you can prevent that, you can lessen the damage by immediately washing it with jets of saline. Just after finishing the UDS, video UDS, you just clean it like anything. Very meticulously clean it with saline, then it will be better.
I think all 4 of us have agreed on most of the questions that we have asked ourselves, or what you have asked. Yes, please. Please sit and ask. Informal.
There is a
Rectal catheter, there is no irrigation. It is the abdominal pressure that you are measuring.
that is okay. I am asking how it is, what is the medium of it is getting transduced. The rectal pressure is getting transduced through a transducer. There it is a fluid in bladder. In rectum, what is this?
No.
Yeah, we flush it.
You are just
Yeah, we
flushing,
flush it.
not irrigating.
We
Just
flush
flushing.
it, but there's no irrigation.
There's no irrigation.
Now it's like a balloon. It's like a Foley's catheter basically, but the Foley's catheter with a pressure measuring tip. It's a Foley's catheter.
No irrigation, only installation of saline.
The end is one end is open. It's a bit like Foley's, where one end is open to measure the pressure. The other one is a balloon. The balloon basically is to make sure that you make the resting pressure. I told you there is a resting pressure. If this is 10, that also has to be 10.
So now coming to the next practical issue. The first urodynamic study on any patient has to be done with all the religious spirituals, as has been discussed. But the follow-up urodynamic studies you can do without the rectal catheter, because you have the benefit of the clinical diagnosis, the initial urodynamic parameters, you have started the treatment, and if you are pretty satisfied with the progress of things, you can do away without the rectal catheter.
Classical example is the neurogenic bladder patients, because they are already on bowel wash. They are having a wash either through malone or through physical wash every day. So we 100% sure that they are empty rectum. And we just want to see the progress of the bladder. So there we can.
That will save you time, energy, and the trauma of the child having a rectal
No, this is
catheter.
Dr. Sudipta also keeps saying, you just measure the vesical pressure and then you're okay if you cannot get a rectal. But if you get a wrong rectal reading, for example, a loaded rectum, and it is going to mislead you in a bigger way. So if your rectal line is causing trouble, just remove it and do a cystometry, and that is actually good enough for you to read, because your mind is now trained to read the bladder, the pattern. Okay.
Another practical tip is, if you are in a soup with your rectal catheter, you can put a NG tube. That will be exactly similar like your rectal. I think we are publishing a book tomorrow, an Atlas of Pediatric Urodynamics. There are at least 200 case studies there. So you will find cases where we had a rectal catheter block. We replaced it with the NG tube. So with rectal catheter, with the NG tube, the curves will look exactly the similar once you have that.
Now something.
Yeah, I mean,
Now, important practical question. Is anything left in the demonstration part?
yeah, everything done? Yes.
Okay.
Can I show the software part also? Yeah, software.
Yeah, yeah, please show, please show.
Any other questions also you can ask.
So this is the IR based system. The connectivity with the hardware and software is based on the IR frequency. And you can see here the IR receiver is actually placed inside this console. So the software is a Phonics V3. Once it will connect with the hardware, it will show the application version and that MAC address of that Euroflow sensor. And you can see here in the header, there is a new patient entry. So the patient information which need to be filled in the software, we will click here and there is some mandatory parts which is first name, that family name, then patient ID and date of birth of that patient. So just I am entering. So now we need to select the investigation type because in this system we can use for the Euroflow, UDS and UPP, so that we need to give the instruction to the software that what we are going to investigate. So first we will click on the new investigation and click on the procedure and then select what the investigation do you want to do that. So for example, if you want to use the Euroflowmetry, just select the Euroflowmetry, and you can also enter the clinician name and operator name. And when we are installing the system, we are asking to the user to provide the clinician name and operator names. After that, we are feeding in the software. So after that, just select the clinician name and operator name and just click OK. It will go to the study. And here you can see uh, the first one is showing the volume of urine, and the bottom one is showing the speed of the urine. So you can see here there is a green button which is for start, and then this is for set 0, this one, and this is for the stop. So once I will start here, I will ask to patient to urinate in this jar, and then once it will done, we will click here stop, and then study will be done. Now I will show you how to do the cystometry here. So just click here again and select the cystometry. Same thing, just select the clinician and operator's name, and you can also make it default. Just click on OK, and it will show the 6 graph here. One is P vesicle, pressure of vesicle. Second one is pressure of abdomen. Third one is a pressure of detusser. Fourth one is a volume infusion. 5 is the speed of the urine. And last is the volume of the urine. You can also add the EMG channel in this protocol. So we have already created a protocol which is adding with the EMG. So now I am showing that. So for that we need to take out the EMG from the cradle charges. then only the Bluetooth of the device will activate and it will connect with the software. So just open it and then click on new investigation again and select the cystometry plus EMG. Click OK. And you can see here the EMG is now coming here. So the value of the EMG is too high because it is not connected with the patient. So the impedance is very high. That's what it is showing here. So this one only. Ah. So these are the settings actually, uh, which we have created in a step by step. So first, what we will do the catheterization to of patient. Then we will do the priming of the transducer and priming of the tubing set. Then it will connected with the catheter. Then we will attach the tubing with the catheter and we will place the patch electrode EMG on the bladder neck at 3 o'clock and 9 o'clock. So after that, just you need to click on start, wait for 2 to 3 minutes because the patient is uh, in a panic stage because just now you have done the catheterization, so the graph will show higher and lower value. It will be fluctuating. So wait for 2 3 minutes. It will be stable, and then just click on set 0. So you can see here
This is a zeroing stage.
zero.
What we do is normally we bring the transducer to the pubic bone of the patient and do the zeroing. That itself, machine adjusts accordingly. So this has to be level 0. So if the child is lying down, we bring it to the pubic bone. Same if the child is sitting even, I mean, normal, ideally, all these things have to be at the level of the patient. But the shortcut is if you bring the transducer, I mean, that poles which is attached, bring here, both they will show you, and put 0. So machine will record that as 0. Accordingly.
Dr. Subhashish, just like I raised a discussion on rectal catheter,
Yeah.
EMG recording in the baseline study
Yeah.
is useful in every case.
Yeah. After that, we can.
Once you have made the diagnosis, the utility of EMG recording is limited
Yeah.
or mostly unnecessary. So if you wanted to do a follow-up urodynamic study and wanted to do a basic investigation, just a single catheter, visual lumen catheter into the urethra, might give you a good idea of what is happening to the patient. But the initial baseline study has to be a properly done study with
Yeah.
EMG
And EMG actually more cost is also involved. EMG gets damaged, very sensitive instrument, gets damaged often and you have to replace it, or I mean either you have to have an AMC with the company and all that stuff. So it's a very sensitive sort of thing. And one technical tip for that to preserve to make its life longer is you charge it before every case. I mean not just keep it charged forever. So like we don't do EMG in most of our cases. In 50% of our cases, we do not do EMG. So only in case I tell her before a day before that tomorrow EMG will be done. So she charges the thing 15 minutes before the study. There's a battery which needs to be charged. In that way, if you don't keep it in a charged state, life is better, at least better, but very costly. So it's not mandatory.
I think we are coming to the end of our discussion. But before we close in, I wish Dr. Sudipta Sen was here.
Yeah, yeah. Missing him.
The two of us seem to have discussion every time we meet,
Yeah,
and there is some disagreement between the two.
always.
The disagreement is on. He is more on the augmentation side,
Yeah,
and I am
same.
not that pro on
Yeah.
augmentation. And I'll tell you the difference. There are two main groups of patients whom you are going to study. A is neuropathic bladder, B is post-renal bladder patients. Now, the post-nasal valve patient has a history of natural burnout. Almost 100% of them are going to enter the phase of reclusive failure between age of 8 to 12. Neurogenic bladder, particularly if they are high-risk neurogenic bladder, there is no natural burnout. It only always burns out. So if you are going to take the defense that my patient is coming from 3,000 miles and is never going to come for follow-up, then you can resort to diversion and bypass, or resort to Botox and bypass, or to augmentation. But that will be acceptable in a public hospital when
Yeah.
patients have no questions to ask. Now, it costs 15,000 rupees to do urodynamics. It costs 1 to 2 days of patients travel to a center where you are located. If doing that much, I can cross over 1 full year safely with normal kidneys. It is worth doing one urodynamic a year so that the clinician can titrate better whether to add some more anticholinergic, add Botox, and cross over a few years so that I can reach puberty without augmentation because the bladder is going to anyway have a drusen solution. I think that is an
Yeah, yeah,
important.
perfect.
So a urodynamic study of 1 year, a urodynamic study at 5 years, and a yearly review.
Yearly review.
What is
Yeah.
the recommendation?
Yeah. And even for the nephrologist, I mean, children needing transplants, they want to defer it as much as possible. So, puberty is the time, at least we want to defer to 10, 12 years beyond that. So,
Thank you very much for coming, participating. We hope all of you start your urodynamic centers. If there is ever any question you want to ask, write to
always.
any one of us. Okay,
So,
and we will help you start.
so now we have two patients. I think one is a neurogenic bladder on whom we will be doing urodynamic cystometry. And there is another patient who will probably will do uroflowmetry for some issue. So she will brief you about, what's your name? But Vanita will just brief you about the patient.
Hello. Our patient, 16-year-old female, is a follow-up case of lipomeningomyelocele who was operated at neonatal period. Now child has neurogenic bowel and bladder, is on CIC on second, third hourly, 180 to 300 ml output, and MCU shows bilateral grade 4 VUR, and DMSA has shows a left kidney 85%, right kidney 15%. Right kidney is small, shrunken with severely impaired cortical thing and irregular cortical outline. Child is on chemoprophylaxis and oxybutynin.
We can circulate, we can pass on the MCU as well as the DMSS scan.
Here actually is being made air free. Air is being flushed out from the system, entire system. Because even a single drop of air will cause problems. Ideally, this should be warm to room temperature, but in our country it doesn't matter much. But it's a dictum that it should have a room temperature, little warm fluid should go in, because cold fluid creates more bladder contractions. It stimulates. Yeah. I mean, in so this is a pressure transducer which is now being attached. So same for this. This is also needs to be flushed so that there is no air. So there are two pressure transducers here. One is this, one is this. So one is rectal, this one is rectal, and this is vesicle. Yeah, 100%. Enema, nowadays we have changed the dictum. What we do is we stop enema. Even the children who are getting enema, we stop them 2 days before. We give them suppositories, because what happens is, even if the child had an enema in the morning, came to us at 10 o'clock, it will continually soiling that time. So basically, whatever bowel wash, etc., 24 hours before. Before that, we just give a suppository so that the regional clearance is there. We don't want to go higher up. And laxatives, whatever, we stop, actually laxatives we stop also 24 hours before, because that creates liquid stool. We just want the rectum to be free, rectum and lower colon, lower descending colon.
Today, before we wind up,
Yeah.
we should remember a great Indian urologist who is not here with us, who has never come to any meeting. His name is Professor S. Vaidyanathan. You know, much of these studies, what we are discussing today, was going on in 1960s in the United States. All this was already known, the stuff being done. And Dr. Hardy Hendren and Ren McGuire were working on this in the 60s, late 60s.
Yeah.
The first publication came out in 17 Journal of Urology. And our premier institutions, PGI Chandigarh, there was a urologist called Dr. S. Vaidyanathan, who would use feeding tubes and manometric measurement of bladder pressure and rectal pressure using transducers for CVP measurement. And everybody would ask him, sir, ये आप क्या करते रहते हो? Including Kailan Rao. And he would say, आपको समझ में नहीं आएगा. You know where he landed up. He became the chairman of the Stoke Mandeville Spinal Unit, which is the best unit in the world for spinal trauma, and is very recently retired. So he's one of those great giants of neuropathic bladder with very deep understanding of urodynamic studies. Hardly quoted anywhere or written anywhere, but since you're writing a book, I think you should locate him.
No. In fact, we have made a chapter. There is one chapter which is written by our Dr. Santosh Karmarkar and his PG, who did a thesis on bedside urodynamics using this thing, what you are saying, that CVP monitor. So that is also, it may not be that accurate, but it gives a basic working knowledge of where we are standing, how much to give anticholinergics, or basic understanding is available even with that inexpensive thing. So we have just intentionally put a chapter on that, how to go for bedside urodynamics in a country like ours. Yeah, no. So we have put a critique. I mean, this is not whatever.
But work done in the 70s was really great at that time. No, we don't lag. We don't lag behind in any knowledge. I'll tell you what is happening. So I'll tell you what. See, they have the benefit of BPH, which is going to develop in every man born at some stage of life. Whereas PUV, which is the collaborative condition or analogous condition in the pediatric age, is going to happen in only 1 out of 5,000 babies born. So the clinical caseload available to us is 1 by 5,000.
Absolutely.
So we do not have the clinical raw material to understand obstructive uropathy of the bladder outlet as well. But that does not mean that our knowledge is not adequate. So to understand the pharmacology, you have to first understand the receptor distribution in the bladder. Anticholinergics will work where the cholinergic receptors are there. Alpha blockers will work well, the alpha receptors are there. Beta blockers will work where the beta receptors are there. And beta agonists will work where the beta receptors are there. Now, beta agonists and anticholinergic blockers have a similar role. So, for example, you are using for a hyperreflexic bladder anticholinergic as the first line. Then, if you are not able to achieve desired effect, you are able to add little bit of beta agonist, and if you have an associated bladder outlet problem, you might try and add a little alpha blocker. Now, when you say bladder outlet problem, the outlet problem can be in the form of an anatomical stricture, maybe in the form of a detrusor sphincter dyssynergia with problems both at bladder neck and external sphincter. So the alpha blockers sometimes work, sometimes don't. And similarly, Botox injected in bladder neck and sphincter sometimes works, sometimes doesn't work. That is all there is to it, and nothing much more than that. Now the trouble is alpha blockers, beta agonists, anticholinergics do have side effects.
Particularly constipation.
And sometimes in children, the side effects can be drastic. Now in adults, those side effects get hidden because the body volume and the body weight is very heavy. In bachas, sometimes they can be very serious side effects and can put the clinician in trouble. If you are particularly professor, HOD, your resident is writing on your behalf, writes a heavy overdose, you can be in trouble. Or for example, you went to inject Botox in good faith. Suddenly the child goes into retention, and for 3 days, 4 days, 1 week, the catheter is there, but 8th day also is not voiding. Now, what face do you have in front of the patient? In an adult, nobody cares. 4 week abhi catheter aur rakho, 2 mahine ke baad aao. In a bacha, it becomes a big problem. So those issues are there. But if you are going to take a deep interest in this area, then your volume of work is going to go up in this area. And then very soon in your community, among your doctors, you're going to be known as a person who's treating these children. And there will be, people will accept it that he is doing this work and it's okay. Yeah.
Those patients who are on anticholinergic and we are planning urodynamics, the medicine should be continued even up to the day of study.
So once again, if it's a question of, say for example, a child has been referred to you or has got self-referred to you because of your reputation from anywhere, but his anticholinergic was started without a diagnosis, then you would ideally stop it for a week and then do the study. But
Say our own patient, we
effect of
start it
6 months of
empirically.
anticholinergic or 1 year of anticholinergic is not going to get wiped away in 7 days of stopping anticholinergics.
Okay.
But in general, if you stop it for 1 to 2 weeks before you do the study, you have eradicated some of the effect of the anticholinergic medication going on.
Like this child was on Tropan. I asked them, Akash called me 1 week back. So Tropan is stopped for a week.
But if it's your own patient who's already on therapy,
we have
and you're
empirically
doing
already
just for the
started.
sake of monitoring the effect of therapy, then you don't need to stop. Another question is frequently asked, how long can we give anticholinergics? I've had patients who are on for 25 years. There's no risk as long as you use anticholinergic in less than the dosage recommended as maximum. 0.5 milligram per kilogram. The CD dose.
So regarding the side effects, sir, you told about the Tropan.
Yeah.
I'm here. So once we had a very bad experience with a case, like often we give in hypospasdias this Tropan. So the child complained of blurring of vision the same next day in the evening. And then it came out to be a narrow angle glaucoma, which precipitated after the second dose. And luckily we could stop and come out with it.
What was the dose of the anticholinergic used?
It was like 0.2 mg per kg BD dose. It was even on the first day, it was only single dose was given.
Are you sure the dose was correct?
Yes, yeah.
I will tell you why. I'll tell you why I'm not willing to buy this story. The tablet size of tropan is 5 milligram. So if I'm a 3-year-old child or let's say 2-year-old child, your common patient will be 1 or 2-year-old. So my dose, correct dose, works out to say 3 milligrams. Now I go take a 5 milligram tablet. I'm told to break it into half. I take half in the morning, half in the evening. I have already taken double the dose. So side effects are dose dependent with anticholinergics, also are idiosyncratic, and we have to be careful with the dosage of anticholinergic, and we should not start with 0.5 milligram per kilogram. In general, we should start with 0.3 milligram per kilogram and build it up in a graduated fashion, and not attack the child with already the maximal dose.
Here we started the thing. We are trying to zero. Kurbo? So this is, see, these are the two curves at various levels. We are pressing here. हाँ, कर दो। तो ये कौन सी EMG ना? Start करें? Yes. Hold on, stop. See, this was here. Now the line has gone to the baseline. ये कौन? Or 350. So her CIC volume is around 300 to 350, like that. 182, that's the range. So we are starting at an intermediate thing. We are starting at 25 ml per minute. And this is the pump. This middle one shows the pump. This one. This is the sign of the pump. Start ko pump. So once we are more or less happy, we will do a cuff reflex to check whether things are in place. Kashi na hoge tarpor ami. So she's flushing now, both the lines. These are the flushes. To be very sure that there is nothing, no obstruction or no air. See, you see the cancellations? This is the cuff. So we are very sure that both the catheter are in place. 0, huh? Huh. Right. Huh. So EMG, you can adjust the amplitude. It should be minimum, so that even the minor variation, you can record.
Has feeling mix started?
No. So now the pump is being switched on. 25. So it's basically 10% of functional bladder capacity. That's the usual thing. We sometimes go up, sometimes there are provocative maneuvers. Like we are expecting that the child has overactivity, but we are unable to record any overactivity on the curve. Then sometimes, yeah, maybe, yeah. And here on the left hand side, there are 3-4 symbols. The above one, the first one is the leakage, that blue dot. So whenever the child leaks, you just press it. It will be reflected down. Second is, one is coughing, that is the third one. The second one is crying or smiling, something like that. Yeah, 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 from uroflowmetry. This pink line will demonstrate that there is some movement. It will show. And next are uh, these are the urge. The first urge, minimal urge, then maximal urge. So severe urge is a blue big one. And the lower to the two red, one is a red flag, one is a black flag. That is when you are asked to void. Command to void is the first one, and the second is when the void has ended. Another good trick after you have started doing a couple of cases is when you are reporting, it's always a good idea to cut the voiding part and enlarge it and give it in a separate diagram. So there are minor variations, these minor variations and nuances of the voiding curve. In a straight curve, you can never find because it's compressed and so much so lost. Once you cut it off and put it in a separate thing, then you can yourself see what are all the voiding curves I showed were separate cut off. Only then you can realize what are the finer details going on. So that's the cuff symbol being put there. Sensation, yeah. এটা কি লিক হলো এখানে?
Okay, so while we are waiting for the pressures to go wherever they have to go, have you explained to the audience what rate you are filling? Done. Okay.
So this is a Valsalva maneuver being done. You blow with port closely. So that is another provocative maneuver. Suppose I'm expecting overactivity is not found, you can do a Valsalva. That means that may a sensitive bladder that will provoke an overactivity. But here there is none. Even during the Valsalva, you can check whether the catheters are in place because they have cancelled. You can see these three movements, they've cancelled in the second. Throughout the study, continually you have to assess whether the catheters are in place. Otherwise, the curves will be generated which have no meaning. So this one is a volume infused. This 72 is the amount of fluid which has gone in. Since the CIC guide is showing us that she passes between 180 to 300 in each void. Void means CIC. So we'll be giving somewhere in between, maybe 250, 200, 250 like that. So with 250 or 200, if there is baseline is normal, compliance is normal, no overactivity, then we know that is fine. And she's off anticholinergics for a while. And this is the lower one is the EMG curve that normally goes up if there is a severe. Normally it goes more in front of so many people, so realize that here now. Normally it goes more to the baseline.
So at one stage in the evolution of the urodynamic understanding, there's something called a natural fill systometry. Fill systometry. So that was thought to give you the best correlationship with what is happening physiologically, because here you are filling up the bladder at least 7 to 10 times faster than here. The truth is that even this is an extremely cautious way of looking at it. So, for example, the baseline study should be done like this. But if you're doing follow-up studies, you have a fair idea of what your patient is, how the tubes are behaving, you can set it up at much higher grade. Because you have the knowledge of at what volume the pressures have begun to rise before you started your anticholinergics and fine. So you can fix a faster rate and no need to waste 2 hours over one study when you're doing follow-up studies. But the first study has to be perfect with all three channels, ectopic, peripheral, perineal electrodes, and slow fill.
So another extension of this this natural fill systometry is, we call it ambulatory urodynamics, which is basically like a halter. So once again, we have a chapter in our book on ambulatory urodynamics. It is done in some developed countries, not in our country. But that also gives you a total estimate. I mean, in front of 30 people, even if I am examined, I might show some abnormal behavior. The point is, natural scenario, what is the bladder, how is the bladder behaving? So ambulatory urodynamics gives you a much more better, longer spectrum, wider spectrum of what is happening. Axoterol, 113 has been infused till now. We don't find much issue.
And there's a lot more to this, and we are discussing this just because we are waiting. This is not actually intrapelvic pressure. So I might be having a high detrusor pressure, but a perfectly normal intrapelvic pressure, unless I'm a reflux inject. The direct communication of the detrusor pressure does not go into become a raised intrapelvic pressure unless I've begun to reflux. Okay. And the danger to the kidney is not happening unless the intrapelvic pressure is rising.
In fact, this particular case, you saw that, I don't know whether everyone saw that, there is a huge reflux on one side and a little reflux on the other side. So, with 130 ml, 5 ml of filling, if there is no, it's not sufficient. Ideally, this child should have done a video urodynamics. So what happens often when we do video urodynamics is, maybe for first 150 ml of filling, we are seeing that it's entirely the bladder. After that, it's going up. Yeah, exactly. There's no point going. And sometimes it happens that after 150, when the bladder is showing overactivity, it is only then it's going up. So that reflux definitely needs bladder management, not reflux treatment. Many patients who have secondary reflux.
How does in a refluxing patient, how does a normal UTI post happen? Really, I'm not seeing
Here we know. So that is why we have to be there in the hall when a UTI when a MCU is being done. So we know exactly
how much after it should be done in real time. No, how much
even if you don't
have a video.
you don't have a video, you do MCU
You
yourself.
MCU in a real time.
Yourself, I would say. When you do MCU, like after 50 ml of filling, reflux started. If someone doesn't have the setup.
No. I'll tell you an easier way. You just bring the patient into the fluoroscopy room and take your urodynamic machine to the fluoroscopy room and add contrast to the syringe which is infusing the saline. Okay. I was trained in a day when all this was not there. Software companies were not making 15 lakhs and 1 crore rupees to fool the urologists. Okay. So all you have to do is to wheel your 5 lakh machine into the fluoroscopy room, add contrast to the syringe instilling saline, and as you are instilling the saline, you do fluoros. So you will know exactly at what step reflux is happening and how reflux is compensating the rise of bladder pressures. And if you find that the pressures are being compensated because of reflux, then you have to imagine how much compensation is safe for your kidney and at which stage that compensation is begun to harm the kidney. And if the compensation has begun to harm the kidney, then you will do something as a surgeon to lower the pressure. Is that acceptable?
Perfect. In fact, that is what we do. We also don't have a video.
No. So in several of these group discussions, I have seen that do an MCU, then correlate, then take the child to urodynamics. I think that is not the way to do it. The way to do it is, but am I able to do what I learned? Answer is no. Because the hospital is not controlled by me. The machine is not controlled by me. When I was working in PGI Chandigarh, there was a different set of problems. Here I have the finest technician. finest machines, but I can't move machines the way I feel like because of the total urodynamics being done in the hospital. The pediatric component is hardly 10%. So at best you can buy a small machine, but you can't decide where the machine will be. But in England, NHS is managed by managers who are brilliant and financially conscious. So they will decide whether radio aerodynamics is to be done in a particular way by a particular machine, or you can get the same physiological parameters by moving the machine in. Yeah,
Images has gone Indian way.
yeah, they didn't have to. So that is what Dr. Subhash is telling you. Yes, you can, but that is not real time. That is MCU being done on a Monday at 9 a.m. in some other location by someone else where you have no data. And what ml reflux appears on right, what ml reflux appears on left, or whatever, grade 4, grade 5, etc., and taking the data, and then your dynamics somewhere else you have done. That is one way, which is inferior to doing it in the same setting in the fluoroscopy room, which is inferior to the current sophisticated methodology where the child goes into one suite and it's done properly, where software is doing all the manipulation.
And even imposition is done by the software. That's the beauty of video aerodynamics. Exactly at what point of this, suppose I this cuffing, if there is a reflex at this point, just below it, another curve will come. That is a fluoroscopy curve. Just on the same curve, it will print out with it.
So now comes the question that in my 30 years of dealing with these patients and having this knowledge, how often have I made an error?
She is actually having an urge to pass
While
away.
using conventional urodynamics? Answer is, in real life, if the bladder is hyperreflexive, you will not miss it. You will not miss it. Even on conventional urodynamics, if you are the one conducting the study, not the technician, and you are conducting it properly by the steps he has mentioned, and you have the benefit of his past history properly, examination, issue data, EMS data, then you are unlikely to miss real high risk lymphatic biopsy reflux. And you are unlikely to miss stratification just because you're not looking for it.
Now we are giving command for start.
Sure. Since this is a neurogenic bladder, even after giving command, is unable to void. She is generating pressure. Even detrusor pressure is being generated, but she's unable to void.
She's getting this position.
Yeah, she's trying to void.
She's trying to. This is a practical issue many times.
Yeah, no, this is because she doesn't void.
She doesn't want.
Yeah.
Many neurogenic bladders like are not able to.
Yeah, void. So it's perfectly all right. So তাহলে ওকে সেরকম
একবার একটু ট্রাই করো তাহলে প্রেশারটা বোঝা যাবে।
So the point is, even with her trying so much and not being able to void, so it's not pressure is not going like
It's not shooting up.
yeah, not shooting.
Still boiling 5
Little amount she had void. If you look at the curve, pink curve there.
Does she have any spinal issue?
Yeah, yeah. It's a neurogenic. Anyone with bilateral reflux. So that was it.
So if we know that she's a neurogenic bladder and she's got a spinal issue,
Yeah.
why are we trying to make her body?
We are not trying. I told her long back to get
No,
this.
I can see your enthusiasm. I can try karo.
This is what? No, there's nothing to see. Nije. This is the third time I'm telling you. So is it clear everything? I mean, you all guys can go and do it. I mean, it's simple. There's nothing.
Acha, I think
Science.
I take it for granted that all of you have got a deep passion for this specialty. That's why you're sitting here in this boring room for 3 hours.
Yeah.
How to do CIC practically? What tools to use? How to store know the tubes, how to wash the tubes. There are million questions. Huh? Just go back knowing one thing. There is no need to wash the tubes. Yes. There is no need to store the tubes. There is no need to use special tubes. The 6 French, the 8 French, and the 10 French will when you wash for 1,000 tubes at a time, cost 3 rupees. This doesn't happen in Europe and America. Here, if you connect with Romson Thomson shop in Agra and say, I want to buy 1,000 tubes for one female, it's hardly 3 rupees per tube. So the cost of CIC per day with 4 tubes is 12 rupees.
That is the safest way.
So it is pre-packed, it is dry, it is clean. Ah, whatever lubricant you want to use, KY or xylocaine or whatever can be in the packet. There are even sachets of 5 ml of lubricant which can be used on foot for 10 rupees. So there is neither the need to keep that xylocaine tube in your pocket, nor the need to carry that CIC kit, nor the need to wash or have anything. The girl or the boy just goes to school or daily life with 5 packets of new tubes costing 15 rupees, with 3 packets or 4 packets of KY jelly or xylocaine, 500 each sachets are there. So if you have a patient, they can buy in bulk and use it for the whole year. So all they need to find is a lube and precision.
Give that option to the patient.
Of
They are
course.
able to do it
Of
on
course.
site. That's
Of course.
they
So
are
if I
not
have to do a daily thing which I am not used to, only if you make it easy for me and give me an easy solution, am I likely to adopt it rather than shall I do it in a lying down position? Shall I do it in a sitting up position? You know, because there are so many days children and parents are put to test by giving them so many options people feeding people साबुन से धो फिर उसको पेपर में सुखाओ फिर उसको ड्राई करो फिर उसको बैग में डालो 5 क्लॉथ का बैग बनाओ you know all that is not necessary. So 15 to 20 rupees a day.
Really, and frankly speaking, most like 80% of our patients are compliant with what he's saying.
They are actually.
They are.
They are.
When we are
And now thing comes on Amazon. You don't have to go. भाई बल्ब घर पे पहुंचा देगा.
I think the options we can give the options to the patient.
Dr. Subhashish, I think you have made a great beginning. Congratulations to you.
There is one more child whose Euroflow will demonstrate. I mean, what? वहाँ होगा यहाँ पे Bluetooth में है. This child is what are doing there, but her group is agree. That's why you know. Every step has to be. By January, it's not free. Yeah. This is what this is. Happy share of first year. Because this one has been received for almost like 3 years now. You see what we must have given. Perfect बता रहा हूँ ये पूरा सर्विस in all machines that was software all the steps same sector. So the chairperson is telling one man, we just attach the machine is the same. Those are the those are
Shubhashish, you want to have a question?
Yeah.
Sir, like where do we connect it to? If we are not using a rectal catheter, what do we do with the? Acha, it stays open in the air, so that doesn't affect the. Okay, okay, right.
Suppose a child cries, child talks, both this will go up,
Hmm.
right? So unless the rectal catheter cancels it, so cancel करने से क्या होगा नीचे वाला diffusal will remain unchanged.
Hmm.
Unless there is cancellation,
It will also
both
go
will
up
move,
with the.
both will move at their own pace. So in a small child, it is very difficult to make out unless you have a rectal catheter. So younger a child is, you always make it a point to the rectal catheter.
Okay.
In a 7-year child, doesn't, it's not required. Yeah. Because unless there is proper cancelling, this diffuser curve has to be sacrosanct. वो हिलेगा, ये भी हिलेगा, आपको guess work करके चलना पड़ेगा. But rectal catheter you place it, it doesn't cost anything. Simple thing, main thing. We don't put it again. We have got a hang of it, how it is behaving. सुबह नहीं करते. We never put it again. कुछ हद तक देख लेते हैं. And if the rectum is loaded, then it always is actually useless putting a rectal catheter. Ulta Siddha, I mean, all strange curves come. Like as I showed you, this like this. That was a normal child, just showing this curve. So if the rectum should be clear, use a rectal catheter. That's it. Okay. reduce तो नहीं करना है कुछ. I couldn't understand what he said actually by reducing. So abdominal pressure, we are taking it for granted कि पूरा abdominal pressure ही एक pressure है. Because rectal pressure anyway.
From abdominal and rectal.
No, I understand, but that is. Oh, sorry. There is no hard and fast rule कितना subtract करना है. Normally, it exactly reflects the abdominal pressure. If there is no crying, or if the child is absolutely still, like in an adult चुपचाप रहेगा ना, so they will be parallel. Detrusor and abdominal pressure will be just run parallel, exactly parallel, unless there are movements in between. बच्चा move कर जाता है, हिल जाएगा सब, I mean everything will go wrong. So it's very difficult. Without a rectal catheter, the child has to be very compliant. Otherwise, rectum has to be clean. Crying, whining nahi chalega. So it's a sort of hypothetical situation. But in adults, it's okay. More than 6 years without rectal catheter doesn't make much difference. Follow up में हम नहीं डालते हैं. We don't put. हमको तो सिर्फ देखना है कि ओवर एक्टिविटी है कि नहीं है. That and follow up में क्या होता है? The children are already tuned कि क्या होने वाला है. They are not afraid at all. They are very happy doing. They enjoy doing this thing. And Indrani is a very friendly lady, so she befriends all children. I always enter the room finding that the child is smiling. I mean, I've never found any child crying with her. She manages so nicely. So never. And doesn't we have some mobile? First of all is we bring the parents to our room when another child is having the study. So half of their apprehension is gone. That is not a dangerous thing. Secondly, I always do the catheterization. With adequate jelly, I wait for at least 5 minutes after giving the jelly. You put in jelly, put in catheter, definitely it's painful. Yeah. So the uroflowmetry has started. So you can just, there is a command has been given. So child is voiding now. So here if you want to particularly, আচ্ছা তুমি কি ওই ফ্লো এর রেড গুলো পরে দেখাতে পারবে, পরে দেখাতে পারবে. So to just check the EMG, we have these are the two cuff reflex we have given before starting. So this is called the lag period. The lag period is the time between the definition of lag period is a time between the starting of the relaxation of the sphincter to starting of void, not from the command to starting of void. It's a because normally in a resting period you will find it's not very obvious here. See, the sphincter has gone up after the micturition has ended. So that is the resting sphincter pressure, which should be high. The moment the flow starts, it should be low, baseline. I have no clue.
He's a normal. This child is a 12 years old child, and he is having just a global developmental delay due to HIE in the childhood period, and there is no urological symptoms in this child. So we were expecting a normal curve on this.
So she's now marking the Qmax and the. So we have two parameters. One is Qmax, which is maximum flow. So we always calculate the residual volume after any uroflowmetry. So so there is a slot to write the residual volume. She's writing here 0 because we. So there are two parameters. One is called P det max and one is called P det Q max. P det max means the maximum detrusor pressure generated during the entire cycle. And P det at Q max is the maximum flow. That's the height of the curve at that point, what is the pediatric? So we have we have actually an article in the JIAPS. You can go through it. So we have studied a lot of things, and we found that pediatric at Qmax gives a better p-value is significant. That gives a better reflection of the bladder problem, especially in PUB. So pediatric Qmax should not be very high. If it is high, it indicates that there is some amount of bladder outflow obstruction, residual, either in the form of a prominent bladder neck or residual valve or stricture or whatever. Yeah, if it is high. So maximum flow, at maximum flow, pediatric.
How much ml per second?
Because if the bladder has to generate excessive pressure at the time of maximum flow, then it is more significant. Yeah, because what happens is, if suppose there is a stricture, so during the maximum flow, because the maximum per unit time, maximum amount of urine is flowing at that point. So bladder, if there is an obstruction, bladder has to generate maximum pressure. That is the one. Other time, the bladder may not have to generate that much.
So what about the post-void residue? Like how will we be able to calculate?
Yeah, we calculate with this thing.
With ultrasound immediately within 5 minutes or so. Immediately.
So ultrasound room, we tell them that the child is undergoing EBS. So there are 3 ultrasound rooms,
whichever is free immediately. We can.
So you see, there is a sphincter activity before starting, which with the command it becomes low, and after that it again gains the baseline. That EMG activity, baseline EMG activity. So this is an ideal curve, which is a good curve. I mean, all criteria are satisfied. We can call it bell-shaped, and most important is this range. I don't have the. This range is from 0 to 50. I was telling you, this same curve, if I make it 0 to 10, it will become a tower curve. And if I make it 0 to 100, it will be plateau. So it's very important. Normally in uroflowmetry, we keep the range at 0 to 50. Yeah, more or less.
Say in a 13-year-old child and I'm doing in a 3-year-old child.
Yeah, 3-year-old child, you can keep it from 0 to 30.
0 to 30.
Yeah.
Is there any specific?
There is nothing.
Guidelines?
Guidelines is what is the average Qmax you are expecting at that age. So at no Qmax flow. This is the flow.
Flow max.
This 0 to 50 is the flow. So I've kept it between 0 to 50 because I know that this child will never go more than, flow rate will not go more than 50. There is a nomogram. In our uroflowmetry chapter, we have mentioned this also. I mean, what is the exact? I don't remember exactly. There are some age-based nomograms.
So the PDET is for the bladder function during the uroflowmetry, and for the lower urinary tract.
Not uroflowmetry. PDET is you cannot measure.
Qmax and PDET only, which we were like how much the pressure the bladder is generating, which we were discussing.
No. I'm sorry. In uroflowmetry, you cannot measure PDET Qmax. So PDET Qmax in cystometry.
Bladder dynamics is for cystometry. Uroflow is the uroflow.
Uroflowmetry, we can only know Qmax, nothing else. Qmax, voided time, voided volume. Now, when is this uroflowmetry inconsequential or something? If the voided volume is less than, I think 30 or some say 30, some say 50% of the expected bladder capacity. Less than 30 or less than 50. If it is less than that, uroflowmetry doesn't have any, you cannot interpret.
Okay, then you can interpret without any.
Even an obstructed system, maybe with a low voiding, will look normal. So it has to be, that voided volume has to be enough.
Less than 50, then we'll negate it. Otherwise, we can.
50%.
50% of the.
Yeah. Yeah, please.
No, that Mahaprasadi is also ready actually.
Let's go.
So thank you very much, and it's very well great thought-provoking discussion was there. So we will end this session now. Thank you.
Sir, excuse me. There is a memento from IAPSCon. So I would request Dr. Sujit K. Chaudhary, sir. तो कौन है? मनोज सर हैं और Dr. Manoj Joshi sir to come on the stage, please. And Dr. Subhasis sir, to please come on the stage. Photographer. Moment to दे दो. Give to each other. Photographer कहाँ है?
Thank you.